Good morning. My name is Maria Navarro, and I'm a third-year general surgery resident and current research fellow at Brooke Army Medical Center. Today, I'll be discussing practice patterns of blunt aortic injury following publication of the Harborview criteria within a military medical center. This work is of my own, and I have no additional disclosures. Blunt aortic injury is the second leading cause of death in blunt trauma, second only to head trauma. While up to 80% of trauma patients die prior to hospitalization, those who survive often present with multiple associated injuries. Therefore, successful management oftentimes requires a circumspect approach with consideration for its pathophysiology, available diagnostic modalities, and current therapeutic strategies. If I may, in taking you through a brief history of the diagnosis and treatment of blunt aortic injury, we begin with landmark trials such as the American Association for the Surgery of Trauma, or AAST1 trial, that have long validated thoracic endovascular repair for adults with thoracic aortic aneurysms, with low rates of paralysis, morbidity, and mortality compared with open surgical repair. While technologic advancements have continued to improve survival and decrease device-related complications, we then evolved to introduce the most accepted and what is most widely used grading system proposed by the Society of Vascular Surgery that, while straightforward and descriptive, fails to guide therapy. And finally, following review of blunt thoracic aortic injuries in a single-center retrospective review at Harborview, simplification of the SVS grading system introduced minimal, moderate, and severe injury categories based on treatment differences among the three groups. When considering timing of operation, mortality, associated injuries, aortic anatomy, and 30-day follow-up, it was suggested minimal aortic injury be managed non-operatively with optional follow-up imaging and antiplatelet therapy. Moderate injuries be managed semi-electively, and severe, although rare, injuries requiring immediate TVAR. And so how do we assess this in our military trauma centers? The aim of the study was to classify trends in the treatment in the period prior to and immediately following publication of the Harborview classification scheme in the military's only Level 1 trauma center at Brooke Army Medical Center. We conducted a retrospective review of 58 trauma patients with blunt aortic injury presenting to BAMC between the years of 2011 and 2023. The eras were defined as pre- and post-publication of Harborview's simplified classification scheme in 2016, and early intervention was defined as operative management within the first 24 hours of presentation to the treatment center. Of the 58 trauma patients with blunt thoracic aortic injury, 20 of those patients were in the early era, so again, before publication of Harborview, and 38 patients were classified in the late era. Their associated classifications are seen on screen left. In evaluating time to intervention from arrival to the treatment facility, there's a noted significant delay in time to treatment, regardless of classification in the late era, a difference of around 18 hours, with statistical significance absent a difference in aortic-related mortality as well as overall mortality. Comparatively, a little over half of patients who were classified as Harborview moderate underwent delayed operative management in the late era, with an average time of around 65 hours between presentation to intervention versus 15% in the era prior, with an average time of presentation to intervention of 20 hours. So what does this mean? To me, it means that severe aortic injuries require immediate repair. Minimal to moderate injuries can be addressed following management of accompanying injuries. Our 40-hour plus difference in treatment between eras allows clinicians to perform procedures in which time is directly correlated to functional outcomes, such as procedures of the spine and brain with subsequent patient stabilization prior to TVAR. In addition, this differentiation between minimal, moderate, and severe guides clinicians in prioritizing the urgency of interventions, particularly in deciding whether immediate or delayed surgical intervention such as TVAR is even appropriate. This is crucial in trauma settings where resource allocation and timing can significantly impact outcomes, such as the transfer of care from a rural to urban setting, or when we think of transferring patients from austere environments to rural threes. This allows us to understand that not all aortic injuries even require immediate intervention, and that can be particularly relevant when you have multiple patients who require urgent care, or even singular patients that require procedures, all of which have the same urgency. And while this study suggests that delayed treatment does not adversely affect short-term mortality, there needs to be further research to answer whether patients with moderate grade injuries require surgical intervention at all. I'd like to acknowledge and thank my mentors, Drs. Hart and Kazi, for their support of this project, as well as a special acknowledgement to my husband, who has the even tougher task of taking care of our baby, which allowed me to come here and present my work to you today. So thank you for your time and obviously the opportunity to come here and present my work. Subject to any questions, that concludes my presentation.